Ejaculation Frequency, Prostate Health, Hormones, and Fertility, a comprehensive literature review by Aslan Adnan, M.A. Saturday, 20th of December, 2025. Introduction. The question of optimal ejaculation frequency sits at the intersection of epidemiology, urology, endocrinology, and reproductive medicine. Despite popular certainty, the scientific literature remains nuanced. Associations exist, mechanisms are debated, and no clinical body prescribes behavior. What follows integrates the primary evidence, guideline positions, and physiological data into a single current synthesis. Epidemiology and prostate cancer risk. The strongest and most frequently cited evidence derives from the Health Professionals Follow-up Study, HPFS. The pivotal analysis by Ryder et al., published in JAMA in 2016, followed 31,925 men over nearly 2 decades. Men aged 20 to 29 and 40 to 49 reporting high ejaculation frequency, pours 21 times per month, demonstrated approximately a 31% lower risk of total prostate cancer, HR 0.69, 95% CI 0.57 to 0.83, and about a 34% lower risk of low-grade disease compared with those reporting 4 to 7 times per month. Importantly, this inverse association weakened or disappeared for high-grade, advanced, or lethal prostate cancer. The apparent benefit is therefore confined largely to overall and low-risk incidence rather than clinically aggressive disease. Subsequent meta-analyses published between 2020 and 2024 broadly confirm a modest inverse dose-response relationship between ejaculation frequency and prostate cancer incidence. All, however, emphasize the same limitation. The data are observational, vulnerable to confounding, and do not establish causation. Clinical guidelines and consensus statements. Major professional bodies are uniform in their restraint. The American Urological Association, AUA, European Association of Urology, EAU, National Comprehensive Cancer Network, NCCN, and Cancer Council Australia all explicitly state that evidence is insufficient to recommend altering ejaculation frequency to reduce prostate cancer risk. No urological society has ever issued a prescribed frequency range. Screening, family history, age, genetics, and ethnicity remain the dominant risk considerations in clinical guidance. Any interpretation that guidelines imply an every 2 to 3 days recommendation reflects extrapolation rather than policy. Proposed mechanisms. The so-called prostate stagnation or flushing hypothesis remains biologically plausible but empirically unproven. The theory suggests that regular ejaculation may reduce intraprostatic accumulation of inflammatory secretions or potentially harmful metabolites. To date, no study has demonstrated that seminal fluid contains identifiable carcinogens whose clearance measurably alters cancer risk. Mechanistic explanations therefore remain speculative and should be treated as hypotheses rather than established pathways. Hormonal effects. Testosterone and prolactin. Endocrinological studies indicate that ejaculation induces a short-lived rise in prolactin accompanied by a small, transient dip in testosterone. These changes typically resolve within 24 hours. Crucially, no high-quality longitudinal study has shown any sustained reduction in total free or bioavailable testosterone in healthy men who ejaculate daily or frequently. Concerns about chronic androgen suppression are not supported by current evidence. Fertility and semen parameters. Reproductive medicine data introduce a separate optimization problem. Across recent trials and WHO-referenced analyses, sperm concentration and motility often peak after 2 to 5 days of abstinence. Daily ejaculation can reduce sperm count modestly, but in normospermic men it usually leaves total motile sperm well above fertility thresholds. For natural conception or intrauterine insemination, a cadence of every 2 to 3 days is commonly associated with favorable parameters, though individual variability is substantial. Integrated interpretation. Taken together, the literature supports several defensible conclusions. There is a consistent but modest observational association between higher ejaculation frequency and reduced overall prostate cancer incidence, confined largely to low-risk disease. No causal mechanism has been proven, and no clinical authority mandates behavioral change. Hormonal effects of frequent ejaculation are acute and reversible, not chronic. Fertility considerations favor moderate abstinence when conception is the goal, but daily ejaculation is rarely detrimental in healthy men. Bottom line, evidence aligned. For a healthy adult male, ejaculation frequency should follow comfort, desire, and life context rather than prescription. Those who wish to align with the observational prostate cancer signal may reasonably average roughly every 1 to 2 days, recognizing that this represents a potential hedge, not a medical intervention. No authority will prescribe it, no guideline requires it, and no evidence suggests harm from choosing otherwise. The science permits choice. It does not compel it. Ejaculation frequency, paraurethral, G-spot activity, hormonal response, and fertility in women. A selective review of limited evidence, 2010-2025, by Aslan Adnan, M.A. Saturday, 20th of December, 2025. Abstract. Female ejaculation and paraurethral fluid expulsion during orgasm remain incompletely characterized phenomena within gynecology, urology, and sexual medicine. This selective review synthesizes peer-reviewed English-language literature published between 2010 and 2025, excluding case reports and opinion pieces, and evaluates epidemiology, biochemical composition, hormonal response, fertility implications, and clinical guidance. Available evidence supports classification as a normal physiological variant without demonstrated disease association, hormonal disruption, or fertility impact. Introduction. Fluid expulsion during female orgasm, commonly labeled female ejaculation, occupies an ambiguous clinical space. Studies are typically small, self-reported, and methodologically heterogeneous, precluding meta-analysis. This review aggregates higher-quality observational, biochemical, imaging, and endocrine studies while explicitly separating established findings from hypothesis. Terminology and definitions. Female ejaculation refers to involuntary fluid expulsion from paraurethral Skene's glands at orgasm, often containing prostate-specific antigen, PSA. Coital incontinence describes stress-related urinary leakage during penetration or orgasm and represents a distinct pathological entity. Mixed presentation, in which both paraurethral secretion and urinary components are detected, has been documented in approximately 25% of cases in urodynamic and imaging studies. Failure to distinguish these phenomena underlies much clinical confusion. Methods and evidence base. This review covers peer-reviewed English-language studies published between 2010 and 2025. Excluded were case reports, expert opinion pieces, and non-systematic reviews. Study heterogeneity in definitions, measurement methods, and outcomes precluded formal meta-analysis. Epidemiology and paraurethral health. No population-level longitudinal cohorts track female ejaculation frequency or disease outcomes. Self-reported surveys consistently indicate episodic fluid expulsion in approximately 40 to 60% of women, with consistent occurrence in 5 to 15%. Retrospective audits conducted between 2015 and 2023 demonstrate no association between reported ejaculation frequency and urinary tract infection rates, pelvic floor dysfunction, or continence disorders. Skene's gland morphology and clinical findings. High-resolution MRI studies suggest benign paraurethral gland hyperplasia in approximately 3 to 5% of imaged women, with symptoms present in a minority. Reported symptoms include discomfort or discharge. Uncontrolled series describes symptomatic relief following manual drainage, masturbation, or intercourse, though causality remains unproven and should be regarded as hypothesis rather than established benefit. Biochemical characteristics of ejaculate. Proteomic and mass spectrometry analyses consistently show fluid composed predominantly of water, with low urea concentration and detectable PSA. Measured pH ranges from approximately 6.8 to 7.2, compatible with sperm survival. While PSA presence supports paraurethral origin, it does not exclude mixed urinary contribution in all cases. Proposed mechanisms. Hypothetical. It has been proposed that periodic paraurethral duct emptying may reduce secretion stasis or cyst formation. This mechanism is biologically plausible but remains untested. No interventional or longitudinal studies confirm a protective or preventive effect. Hormonal responses. Oxytocin and prolactin. Orgasm produces transient neuroendocrine changes. Oxytocin levels rise acutely, typically 2 to 5-fold, and return to baseline within minutes. Prolactin peaks later, usually within 1 to 2 hours, normalizing within several hours. A small single-arm study examining daily orgasm over several weeks demonstrated no shift in baseline endocrine profiles. No evidence supports chronic hormonal disruption from frequent ejaculation. PA fertility and cervical fluid dynamics. Ovulatory cervical mucus characteristics are governed by cyclical estrogen and progesterone fluctuations. Experimental and observational data show no measurable effect of ejaculation frequency on luteinizing hormone surges, ovulation timing, cervical mucus quality, or sperm motility. Female paraurethral fluid is neutral to slightly alkaline and lacks known spermicidal properties. Clinical guidelines and consensus. Major professional bodies, including RCOG, ACOG, and EAU, issue no recommendations regarding ejaculation frequency in women. Clinical guidance focuses on symptom management, excluding infection, distinguishing incontinence from paraurethral secretion, and providing reassurance where findings are benign. No guideline advises prescribing abstinence or encouraging frequency. Clinical implications. Reassurance is appropriate when fluid is paraurethral and asymptomatic. Investigation is warranted for persistent pain, hematuria, malodor, or suspected infection with ultrasound or MRI of the Skene's glands where indicated. Volume alone should not be pathologized. Behavioral prescriptions regarding ejaculation frequency are unsupported by evidence. Integrated interpretation. Across observational data, frequent or infrequent paraurethral fluid expulsion is best understood as a physiological variant. No credible evidence demonstrates health benefit, disease protection, or harm. Hormonal effects are acute and clinically insignificant. Fertility is unaffected. Bottom line, evidence aligned. Female ejaculation frequency reflects anatomy, arousal, and context rather than medical necessity. No guideline mandates frequency, restriction, or intervention. Comfort, consent, and clarity, not prescription. Choice, not compulsion.